Good morning, everyone. My name is Micaela Santos, and I will be discussing about thalassemia, G6PD, and hemophilia. So, these three diseases are genetically inherited blood diseases, and they have a very similar anemic nature and management, but they have different pathophysiologies. First is thalassemia. It is an inherited blood disorder characterized by deficiencies in the rate of production of specific globin chains in hemoglobin. So as you can see, this is a normal RBC compared to a thalassemic RBC. They are malformed and microcystic or smaller. So because of that, they don't function properly and they last shorter periods of time. So with that, fewer healthy red blood cells are traveling in the bloodstream, causing anemia and leaving the body fatigue. So there are two types of thalassemia, alpha thalassemia and beta thalassemia. So this refers to the part of hemoglobin that isn't being made. To further explain, this is a picture of how hemoglobin is made up. So a hemoglobin is composed of four globin chains, which are alpha, beta, gamma, and delta. So these globin chains make up the three kinds of hemoglobin, which are hemoglobin F fetal, hemoglobin A adult, and hemoglobin A2, which is also adult. Hemoglobin F is composed of 2 alpha and 2 gamma. For hemoglobin A, 2 alpha and 2 beta. And for hemoglobin A2, there is 2 alpha and 2 delta. So since there is only since the most common kind of thalassemia affects alpha and beta globin chains, the most affected kind of hemoglobin would be, of course, hemoglobin A because it is both composed of hemoglobin alpha and beta. So this is a quick flow chart of the pathophysiology of thalassemia. So since there is a reduced level of beta globin chains, there is excess free alpha chains, causing hemolysis, ineffective erythropoiesis, membrane damage to peripheral RBCs, and it would all result to anemia. Then signs and symptoms would follow. The only risk factor for disorder, but the parent has only two or down the chain. That would be the same for beta. But for alpha thalassemia carrier, it is where only one gene is missing. So usually no signs or symptoms, but they are able to pass down the thalassemia to their children. For a thalassemia minor or trait, it is where RBCs are smaller and sometimes very slight anemia. So this is where two genes are missing. For each disease, signs and symptoms will be moderate to severe. Three genes are missing in each disease. And for A thalassemia major or hydrops fetalis, there is four genes missing. So this may lead to a fetal death or a newborn baby dying shortly after birth. So as you can see, if a baby has hydrops fetalis, their liver would be swollen and there would be severe abdominal swelling. A chance of surviving after birth. Signs and symptoms are fatigue, weakness, shortness of breath, a pale appearance or jaundice, irritability, deformities of the facial bones, slow growth, a swollen abdomen, and dark urine. So the types of beta-thalassemia, for beta-thalassemia minor or trait, there is mild anemia, but there is no need for any medical treatment. for beta-thalassemia intermedia, moderately severe anemia, and some need regular blood transfusion. But for those with beta-thalassemia major, also called Cooley's anemia, they have severe symptoms and life-threatening anemia, so they need regular blood transfusions and other medical treatment. Signs and symptoms are tiredness, shortness of breath, a fast heartbeat, pale skin, yellow skin or jaundice, moodiness, and slow growth. So this is what a person with Cooley's anemia look like. They have bone abnormalities, usually in the skull, hypertrophy of the maxilla, exposing the upper teeth, depression of nasal bridge, and periorbital puffiness. For their bodies, they have hepatosplenomegaly and wasted limbs in their untransfused case of beta-thalassemia major. Diagnostic tests are, of course, there are CBC, iron studies, skeletal survey, and ECG. But if the fetus is suspected to have thalassemia, there are also tests for it, which are chorionic villus sampling, good for 11 weeks into pregnancy, and it involves removing a tiny piece of the placenta for testing. It also, this would also be used, which is amniocentesis, good for 16 weeks into the pregnancy, and of course, it means it involves the fluid that is surrounding the fetus, the amniotic fluid. For medical management, these are splenectomy or removal of the spleen, of course, blood transfusions, bone marrow transplantation, and diet. So encourage diet high in folic acid, small doses of vitamin C and vitamin E. So iron should be avoided. Um, Pharmacological management are antipyretic, antihistamines, chelating agents. So this is used to chelate excessive iron from the body in patients with iron overload. Next is antibacterial combinations, vitamins, anti-neoplastic agents, and growth hormone. Nursing assessment. So the most we need to manage is thalassemia major and thalassemia intermediate. So we need to assess for severe anemia, splenomegaly or hepatomegaly with abdominal enlargement, frequent infections, bleeding tendencies. For thalassemia intermediate, assess for anemia, jaundice, and splenomegaly, hemosiderosis caused by increased intestinal absorption of iron. Nursing diagnosis first is an effective tissue perfusion related to reduced cellular components that are essential to deliver pure oxygen to the cells. Next is activity intolerance related to imbalance of oxygen supply and consumption of needs. Third is imbalanced nutrition less than body requirements related to lack of appetite. The main objective and goal of supportive therapy for thalassemia patients is to maintain sufficient hemoglobin levels to prevent tissue hypoxia. For nursing interventions, we assist the client in developing a schedule for daily activity and rest, encourage deep breathing techniques, and administer oxygen as prescribed. In health education, explain the importance of the diagnostic procedures and the hematological vocabulary and the functions of blood elements. Educate the client and the family regarding food rich in iron, folic acid, and vitamin B. In preventing of infection, assess for local or systemic signs of infection. Instruct the client to avoid contact with people with existing infections. Instruct the client to avoid eating raw fruits and vegetables and uncooked meat. Stress the importance of daily hygiene, mouth care, and perineal care. Teach the client and visitors the proper hand washing. So, in preventing bleeding, assess for any frank bleeding and monitor platelet count. Instruct the client about bleeding precautions, such as to use electric shaver, not razors, use of soft toothbrush when brushing the teeth, use pads instead of tampons, avoid rectal procedures such as suppositories and enema, and use water-based lubricant during sexual intercourse. Next is G6PD, or glucose 6-phosphate dehydrogenase deficiency. So what is G6PD deficiency? It is an X-linked enzyme deficiency disorder that causes hemolysis. So G6PD, it is an enzyme that helps the body use sugar for energy. G6PD, they create NADPH, which is what helps protect the RBC from the oxidative stress. They help protect from free radical damage and convert oxygen to superoxide in neutrophils to fight infections. So G6PD is important because without it, there would be no NADPH, and without NADPH, our RBCs are very much in danger because they would be very vulnerable to oxidative stressors. So signs and symptoms are jaundice, sudden rise in body temperature, dark urine, fatigue and weakness, shortness of breath, rapid heart rate, confusion and difficulty, and high risk of enlarged spleen. So what are these oxidative stressors? So these are usually the antibacterials, antimalarials, and environmental or food, which are faba beans and naphthalene. So faba beans is very much associated with the G6PD deficiency because it is a very much avoided food when it comes to persons with G6PD deficiency. For diagnosis and treatment, um, they use Heinz preparation, tegmasites and Heinz bodies, enzyme studies, but the gold standard for quantifying G6PD enzyme activity is spectrophotometric analysis. So it provides an weighted average of the activity of the normal G6PD to the deficient G6PD. So the only treatment for G6PD deficiency is to avoid the triggers, which is the oxidative stressors. Nursing assessment, health history and physical exam. It is data about the type of anemia involved. So it shows the extent and type of symptoms and the impact of it to the patient's life. For medication history, there would be some medications that can depress bone marrow activity, induce hemolysis, or interfere with folate metabolism. Assess for history of alcohol intake, family history, and athletic endeavors, and also nutritional assessment. Nursing diagnosis first is fatigue related to decreased hemoglobin. Second is altered nutrition less than body requirements related to inadequate intake of essential nutrients. And third is altered tissue perfusion related to insufficient hemoglobin and hematocrit. The usual goal and objective for hemolytic anemia in G6PD deficient patients is supportive care plus removal and avoidance of further triggers. Nursing interventions to manage fatigue assist the patient in prioritizing activities and establishing time for rest. For physical activity, promote physical activity and exercise because it helps prevent the deconditioning that results from inactivity. To maintain adequate nutrition, the nurse should encourage a healthy diet that is packed with essential nutrients and to avoid foods that are triggers, such as fava beans. In alcohol intake, the nurse should inform the patients that alcohol interferes with the utilization of essential nutrients and should advise the patient to avoid or limit his or her intake of alcoholic beverages. In dietary teaching, sessions should be individualized and involve the family members and include cultural aspects related to food preference and preparation. To maintain adequate perfusion, of course, there would be blood transfusion. So, as a nurse, we should monitor the patient's vital signs and pulse oximeter readings closely. To promote compliance with prescribed therapy, the nurse should assist the patient to develop ways to incorporate the therapeutic plan into everyday activities. Teach the client medications that can be taken and medications that should be avoided to prevent these triggers. So last is hemophilia. It is a rare blood disorder in which the ability of the blood to clot is impaired. So the body doesn't make enough protein called a clotting factor. So there would be mild and severe. For mild, there would only be longer bleeding than normal after an injury or surgery. But for people with severe hemophilia, they might bleed for no reason at all. So there are two types of common hemophilia. First is hemophilia A, which is also known as type A or classic hemophilia. It is a um, factor 8 is absent, which is needed for conversion of prothrombin to thrombin to thromboplastin component. So these are the usual signs and symptoms of it. So there is um, prolonged nosebleed, bruises easily intracranial hemorrhage, warm, painful, swollen joints with decreased movement. Next is hemophilia B, which is where factor 9 is absent. So it is also known as Christmas disease. So when I say factor 8 and 9, so this means that it is part of the coagulation cascade. So it is the steps that occur during the formation of a blood clot. So it is part of the clotting factors. So whenever one or two of these factors are not functioning well, there would be longer bleeding and lesser ability of the clotting factors to function. So signs and symptoms, of course, there is ecchymosis, easy bruising, hematomas, prolonged bleeding, GI bleeding, hematuria, and severe nosebleeds, and hemarthrosis. So we need to be very um, we need to keep in mind that this bleeding would be life-threatening to patients, most especially if there is bleeding in the brain. It may cause headache, vomiting, sleepiness, or seizures. So risk factors. So since it is an X-linked recessive, um, the risk factors are, of course, it's genetically inherited disorder. So since it is an X-linked recessive, it means that the hemophilia gene resides in the X chromosome. So this is most common in males because since males have only one X chromosome, they would not be able to function well if their X chromosome is compromised. But if in females, we have two X chromosomes. That is why if ever the mutated chromosome would be affected, there is still another healthy X chromosome. But they would also still be a carrier, and there are still females who has hemophilia. For diagnostic tests, clotting factor test or factor assay is required to diagnose a bleeding disorder. This shows the type of hemophilia and severity. So this is a chart as to how to um, categorize what type of hemophilia the patient has. Other than the clotting factor test, there is also screening test, CBC, activated partial thromboplastin time test, and protothrombin time test, and fibrinogen test. Assessment. Assess for patients in whom hemophilia is suspected. Inquire about the history of hemorrhage disproportionate to trauma, history of spontaneous hemorrhage, bleeding disorders in the family, and the concomitant illness. Assess for physical examination, assess for joint swelling and ability to move affected limb. Assess for limited ROM, contractures, and bony changes in the joints when bleeding has stopped. Nursing diagnosis first is acute pain related to traumatic injury to the muscle. Second is impaired physical activity related to pain and discomfort with the onset of bleeding episodes. Third is risk for bleeding related to decreased concentration of clotting factors circulating in the blood. And fourth is risk for injury related to decreased clotting factors. The nursing care plan goals for a client with hemophilia may include absence of complications and pain, preventions of injury and bleeding, improved physical mobility, and understanding of the disease condition and its management. Nursing interventions in first is to relieve pain, immobilize joints and apply elastic bandages to the affected joint if indicated, elevate affected area and apply a cold compress to active bleeding sites. Next is to maintain optimal physical mobility. Provide gentle passive ROM exercise. Educate on preventive measures such as the application of protective gear and the administration of factor products. Next is to refer for physical therapy, occupational therapy, and orthopedic consultations as required. In prevention of bleeding, monitor hemoglobin and hematocrit levels, anticipate or instruct in the need for prophylactic treatment before high-risk situations, provide replacement therapy for deficient clothing factors, educate the patient and family members about signs of bleeding that need to be reported to a healthcare provider. And in prevention of injury, utilize appropriate toys. So this is for infants or children. They may need to use padded bed rails on crib. Next is to avoid rectal temperatures or rectal procedures such as enemas. Provide appropriate oral hygiene such as the use of soft toothbrushes and to avoid contact sports such as football, soccer, ice hockey, and karate because this may cause injury to the hemophilic patient. So that would be all. Thank you.